Welcome back. Today we're going to be discussing Chapter 5, which is medical terminology. So some topics we're going to be covering is what is medical terminology, the language of anatomy and physiology, and some anatomic terms. So medical terminology, it's the language that you are going to have to be using both understanding and speaking it. We also need to understand that there are instances where we shouldn't be using this, especially if you're talking to patients. If you've ever been to like a primary care's office and you get a diagnosis of something, have you ever had an instance where the primary care has told you, this is what you have? They may have used an acronym, and when you left, you had no idea what they were saying, so you don't know what exactly is going on with you. That happens a lot with our patients, and it's something that we need to avoid. And it's also something that we need help decipher, because sometimes we're called because their doctor's office called them and said that they have XYZ disease. And they have no idea what it is, and so they call us and they're asking about it sometimes. So we really do need to have a firm grasp on medical terminology and when not to use it. So most medical terms are compound words. Compound words are words that are made up of two or more words put together. You'll have a prefix, which it goes in the first half of the word, a root, which is what the word surrounds, and then a suffix, which goes at the end of the word. So if you use a prefix and a root, or a prefix, root and suffix, or just a root and suffix, or a root and two suffixes, you can combine all those and make up words. So it's really important that we learn some of the common prefixes, suffixes, and some of the common root words that are used. And then it's just a game of mixing and matching these to form the word that we're using for medical terminology. So, for example, the word smallpox on this slide is composed of small and pox. That's a compound word. And here it kind of breaks down how things are broken down, like I just said in the last slide. You have roots. One of the root words is therm, and that means heat. And then if you combine therm and meter, and you put an O in there just to make it go a little bit smoother when you're saying, you can get thermometer. So that's measuring heat. Therm and meter is thermometer. Some prefixes that they use one is dis, which means difficulty. Another one's tachy, which means high. And PNEA, peanut, is breathing. So if you put the prefix, these two prefixes to the root word breathing, you have dyspnea, which is difficulty breathing when you put those two together. And you have tachypnea, very hard word to say. And you put those two words of high and breathing, you get fast breathing. Then some suffixes that they have here. You have arthritis. Arthur is the root word for joints, and itis is inflammation, so that's inflammation of the joints. And hemophiliac, hemophil is root word for blood clotting, and iac is the suffix for pertaining to. So hemophiliac, strictly translated, means pertaining to blood clotting. Here's another example of how we are combining prefixes and root words. So you have tachy, which is a prefix meaning fast, and cardia, which is a root word meaning heart. Put that together, you get tachycardia, which means fast heart rate. That is a term that we will be using in class from here on out. Another one, you have hemo, which is the root word for blood, and thorax, root word for chest. Put those two together and you have hemothorax, which means blood in your chest cavity. Third example we have here is cardiologist. So the root word in here is cardio, which means heart. Logi means study of, and ist means one who specializes in. So you throw that together and you have a word that means one who specializes in the study of the heart. So most of these words that we're going to encounter in EMS, if you don't know it, it usually can be broken down into your root words and your prefixes and suffixes. So as long as you know the common root words, suffixes, and prefixes used, you should be able to decipher most things, even if you've never heard the word before, because there is so much out there for medical terminology. I haven't heard everything out there before in my career. You won't hear everything in your career, so you're going to be constantly hearing new words. And medical terminology in college is a full-on class that you can take for an entire semester. And we're dedicating one class of EMT class to this. So I can't teach you everything in one sitting, but as long as you get the basics and you can start breaking words down, hopefully that will give you a good start of how to proceed in your career with deciphering words. So abbreviations and acronyms. Abbreviations are initials that we use to shorten a word, like CPR is an abbreviation for cardiopulmonary resuscitation. A lot easier to say CPR. And an acronym is an abbreviation that can be pronounced as a word. So in CPR, you have to say each individual letter of that acronym. But something like CPAP, CPAP, which stands for continuous positive airway pressure, is pronounced CPAP, not CPAP. So because we can pronounce it as a word, we don't have to say every single initial. That makes it an acronym versus an abbreviation. So right here is a example of abbreviation, DNR, which means do not resuscitate. So as I discussed at the start of this chapter, there's a lot of times when we shouldn't be using medical terms. When you're talking to your patients or family members, try to put things in as plain language as possible. Don't be using abbreviations. Don't be using your fancy medical terms. Unless it's something very commonly accepted, stay away from it. And people know what arthritis is. You can use arthritis as a word. People don't know what pericarditis is, though. So instead of saying pericarditis to someone, break the word down and say that you have swelling in the area of the sac that surrounds your heart. So make sure that you can be able to interpret medical terminology, because it's going to be said to you from doctors, nurses, other medics, but also be able to translate it and put it back out into plain English when needed. But also know when you can use it when you're talking to other healthcare providers, so that there's no confusion between plain English and medical terminology when you have to describe something to another medical professional. So right here is a list of some common medical abbreviations. I sent this out to the entire class. The danger behind medical abbreviations is not every abbreviation means the same thing to the same people. An example I always give is PA. To most people, PA is the abbreviation for physician assistant. That's usually widely recognized as that abbreviation. But if you look at it in different contexts, like say you were mailing an envelope, PA means Pennsylvania. Or if you're in the insurance field, PA means prior authorization to do a procedure. Or if you have this disease, PA could mean psoriatic arthritis. So there's a lot of different meanings just for that one abbreviation. The problem with using abbreviations, especially in documentation or any time when someone can't ask you clarification, is sometimes it can mean something to the reader that it didn't mean to you when writing it. So we really try to stay away from using medical abbreviations, especially in documentation, just so we don't have any confusion between providers when we're reading each other's charts. Because if you do confuse something in a chart that you write and the emergency department staff is reading it, they might change their course of treatment based off of what you wrote. So we want to be as clear and as plain as possible when we're using documentation. So that being said, here's a list of some common medical abbreviations. I'm not going to go through every one of these because the list was sent out, but definitely review it. This by all means is not an all-inclusive list. This list is just some of the common ones used, and it expands and contracts almost every single day. So just be aware of some of these. One thing I do want to point out is there are a few of these, like right here, dx. Anything with an x after it is very widely left for interpretation. Dx to one provider can be something completely different than dx to another one, just because there is no standardized abbreviation that has x in it. So dx commonly means diagnosis for us, but dx can mean something completely different from someone else because it's more of a personal interpretation. So really avoid using anything with an x after it. There's a few on this list. Dx or diagnosis. Hx can be history. So just read through this, be familiar with them, but really try to limit your use of medical abbreviations. So I'll stay on this slide for just a few seconds. If you need to pause the video to look through all these, feel free to. And this is the end of this list. If there are any questions of some of the abbreviations on here, always feel free to reach out to me to get some clarification on what something means. If you aren't used to using UHF and you just see ultra high frequency, you might not know that refers to radio frequency, and that's something we'll discuss in EMS operations. But if there's anything on here that you aren't really sure what it means, feel free to reach out to me. So this is another handout that went to the entire class. This is just a list of some common medical specialists out there. We should be familiar with some of the major ones out there. This is by no means an all-inclusive list. It's just some of the more common specialties out there. And that's just so we can communicate with our patients better. If the patient says that they were at their oncologist, you should know that that means that they have a history of cancer at some point. So they aren't, a lot of people just say, I have an appointment with my oncologist, and they won't say, oh, I have this type of cancer straight out in front of you. But when they say that they're going to an oncologist too, that can be your trigger to be like, oh, what type of cancer do you or did you have? Why are you going to the oncologist? So just being familiar with this list is huge to being able to do our job effectively. So take a second, read through this list. Again, if there are any questions, always feel free to reach out to me. Right here is a list of common roots, prefixes, and suffixes used in medicine. This list is found on page 100 of your textbook. So this is a word-for-word copy of that page. One prefix I want to add to this list that should be there is just the letter A is a prefix for without. So if you take something like the root word of lungs, or breathing, which is a suffix, but it can also be used as a root word. So breathing right here, P-N-E-A, that's a suffix for breathing. Could be a root word in my opinion. And you put A in front of it, which means without. That combined means without breathing. So apnea, which is a very common word that we use for someone who is not breathing. That's the correct medical term to use for that. So remember, A means without is something that should be added to this list. I do have some memory tricks to remember some of these prefixes and suffixes and root words. If you need some help studying it, feel free to ask me. I can give you some tips and tricks behind these guys. This list right here is something that you should know by heart, really before the end of section 1. So make sure you know every single one of these. I'll be able to test you on any of these and be able to combine any of these words to form a medical term. So be aware of that this is something you should know backwards and forwards. So this is just a medical term video. It's nothing real much in there. We did show it in class. Same with this, just another video. This one discussed some of the medical specialties. If you go to that list, it pretty much just covers what we covered in the list of medical specialties. So moving on to the language of anatomy and physiology. This class is on medical terminology, so we don't want to touch too much on anatomy and physiology in this class, just because we have a whole class dedicated to that. I believe it's chapter 7. So, or correction, chapter 6. So the only big thing that we want to touch on this is anatomy is the study of a body structure, and physiology is the study of a body function. So anatomy is saying your heart is shaped with kind of bigger at the top and then comes down into a tiny apex at the bottom and is located in the left side of your chest. That's the anatomy of the heart. It's the size of the structure where it's located. Physiology is how it functions. So the heart has its own electrical pathways, and it contracts and relaxes, which will pump blood around and through it so it can get to the body. So that's the physiology of the heart. So let's remember that anatomy is the study of the actual structure, and physiology is the study of the actual function. That is something that we do need a big, firm grasp on. We'll cover it more in anatomy and physiology, but know those terms for today. So moving on into anatomic terms. And this is really the meat and potatoes of this class. Anatomic terms is how we communicate effectively between medical providers, which is crucial for EMS because not only do we document our calls and we have to explain to people reading our charts what we see, but we also in real time have to communicate with a doctor at the hospital if you need to call medical control for some reason and explain an injury. Say you have a bad trauma patient that's coming in, you need them to be able to prep to take this patient in. You need to be able to precisely describe what's wrong with your patient. And so we need to have a universal language that we use so that one person talking to another person in the medical field knows exactly what we mean. So we have a lot of different terms and we have a lot of different standards that everyone in the medical field follows. That's what this is going to be discussing. So this is very, very important to actually know. And this is what we're going to be using for the rest of the class when we're talking about the body. So this is definitely have to memorize this material. So we're going to start out with the anatomic position. The anatomic position is the position that we reference anything to. So whenever you have an injury that you're describing, you have to picture the anatomic position as you're describing it. The anatomic position is facing forward, your hands are down at your sides, and your palms are facing forward towards the person looking at you. So this position makes it so that there's no discrepancy in what's front or what's back of the human body, because someone who is normally standing will have their hands at their sides and their thumbs are facing out, their palms are facing in towards their body, or they might have them where the palms are facing backwards. So this gives us standardized, your palms are out facing the viewer. So whenever we describe anything, that is the position that we are referring to. It's called the anatomic position. Anatomic position is definitely something you're going to know. It's going to be tested on. In the anatomic position, your body is divided into several different planes. We're going to get into some of these different planes, but the biggest one is your midline. Your midline runs down the middle of your body. So it goes between your eyes, runs straight down through your belly button, and really ends at your pelvis, right where your legs break off. You could theoretically run down your legs, but really we generally don't. So it will go from the top of your head down to where your legs branch off. When we're talking about the midline, we talk about whether we are closer to the midline or further away from the midline. So closer to the midline is called medial. If you think of a median in a highway, the median is between the two lanes, so it's closer to the middle of the entire highway. And then lateral is further. I always think about a lateral pass in football. A lateral pass is a pass that's goes straight to the side, so it goes further away from the origin. So lateral is further, medial is closer. Those are key terms that you are going to have to know. So an example that this can be used in is if you have a laceration to the chest and it's between your midline, so sternum area, and your nipple, you can say that the cut is 3 centimeters medial to the nipple. That's an example of how we can use medial or lateral when describing an injury. Some other terms that we're going to be using, bilateral means both sides. If you break it down, this has a prefix and a root word. So lateral is your root word if you break it from here. So lateral means side. And then bi means two. So if you think a bicycle has 2 wheels. And then unilateral, break that, we have side. And then uni means one. If you think of a unicycle, has 1 wheel. So unilateral means one side and bilateral means 2 sides. An example that we can use this in is saying that a patient has bilateral femur fractures. That means that they have a fracture in their femur on both legs, which is commonly seen during car accidents. If you have enough force to break one, oftentimes you break both in a car accident. Unilateral, on the other hand, we can say someone has unilateral weakness, which means weakness only on one side, which is something that you see in strokes when the deficits of a stroke are only found on one side. It's called a unilateral deficit or weakness, depending on what you're talking about. Another line that we need to be familiar with is the mid-axillary line. The mid-axillary line runs right from the middle of your armpit down the side of your body. So that's the mid-axillary line. If you have ever taken an axillary temperature, that's a temperature in the armpit. And that's how you can remember the mid-axillary line. It's the middle of the armpit. So here are some directional terms, and these are must-know terms. So your anterior is the front. So if you're looking at your anatomic person, when you're looking at the front of the person, the face, the chest, the palms facing out, that's their anterior view. Posterior, on the other side, is the back. So anterior is front, posterior is your back view. Superior means above. If you remember, supervisor is above you. So superior means really closer to the head. So if you have an injury that is closer to the head, like say you have a laceration on your abdomen, that laceration could be 2 inches superior of the pelvis. Inferior, on the other hand, means below. So if someone's your inferior, they're below you on some sort of scale that you're using. So inferior in anatomical terms means below something. So if you think towards the feet is inferior, towards the head is superior. So anterior is your front, posterior is your back, superior is towards the head, inferior is towards your feet. Some more must-know terms. Proximal means closer to the torso, and distal means farther from the torso. These are really used in extremities in your arms and your legs. So say you have a cut on your upper arm, that cut is proximal to your elbow because it's closer to your torso from your elbow, but it's distal from your shoulder. So it's further away from the torso than your shoulder is. Typically, when we're labeling injuries, we go from the bigger joint of reference. So in that example of the upper arm, yes, you could say proximal to the elbow and distal to the shoulder, but the shoulder is a bigger joint than your elbow. So we typically refer to an upper arm injury as being distal from the shoulder. A couple other terms. Palmar means palm of the hand. That has palm in the word, so it's pretty easy to remember. Then plantar means the sole of the foot. If you ever watch sports, a lot of athletes come down with plantar fasciitis, which is something affecting the sole of the foot. So that's how I always remember plantar being the sole of the foot. But proximal and distal are 2 very key ones that we have to keep in mind. It's very similar to superior and inferior, but we tend to use proximal and distal when we're talking about extremities versus superior/inferior. So here are some directional terms, and really what this should be is reference points. So these are all pointing out some of the major areas of the body that we can use for references. Like I just said before, we had a cut that was in our upper arm. It's between the elbow, which is a commonly referred to area, and the shoulder, which is a commonly referred to area. So, so we have that cut that was distal to the shoulder. That's an appropriate term to use because the shoulder is a commonly known area of the body. So this covers the rest of some of the commonly known areas that we can reference. Excuse me. Some of the big ones, your head can be separated into your cranium, which is where your brain is, and then your face. Then your face will have your jawbone, which is called your mandible. That's a commonly referred to area. And then you have your neck as a whole. Then your chest cavity right here is called your thorax. So that's how we refer to the chest cavity. You also have your abdomen as a whole, where we talk about abdomen a little bit. Then you have your pelvis right here, where your hips are. Then you have your thigh, your knee. I do upper leg up here instead of thigh, and then we have lower leg down here. Ankle and foot, so that's your leg right there. Then on your arm, you have your shoulder, upper arm, elbow, forearm or lower arm. I usually use lower arm, wrist, and hand. So right here is a good visual representation of the different directional terms that we have. So as you can see, we'll start over here. This is proximal is going up towards the torso, distal is going further away. So that's your proximal distal representation. Here you have your midline, right there. Then going towards the midline is your medial, and going away from the midline is your lateral. And then right here, we've got two lines. We're going to discuss this in a second with the slide. But these two lines are known as your midclavicular lines because your clavicle is your collarbone right here. And so midclavicular means middle of your collarbone or clavicle. And that will help us divide the chest into two separate sections. So we can say something is closer or further away from the midclavicular line. If we look over here, we have a visualization of your anterior and posterior view. This is an anterior view in the anatomic position because you can see that the palms are facing out. Then posterior view is the back. And then going towards the head is a superior aspect. Going away from the head towards the feet is your inferior. And right here is your mid-axillary line. You can see it goes right through the middle of the armpit, runs down the body on the side. So these are needed to know directions and terms. You have to have this down pat. So like I said, midclavicular line divides your chest into two regions. Since we have two clavicles, there are two midclavicular lines. So you have your right midclavicular and your left midclavicular. Moving on, we have some planes. Planes aren't really used all too much in practical EMS work, but you have to be aware of the planes. So you have three different planes. You have one that runs down the middle of your body. This plane is known as your sagittal plane or your median plane. Median is a lot easier to remember. Then you have a plane that cuts right through the middle of your body around your mid-axillary line. That is your frontal plane. So it divides the body into the front half and the back half, your frontal plane. Then you have your transverse plane. That goes right at your hips. And that divides the body in between your upper half and your lower half. If you think about it, your median plane runs down your midline. Your frontal plane runs down your mid-axillary line. So that's why we don't use planes all too often, because we have lines that we reference instead of planes. So moving on into your abdominal quadrants. So the abdomen has a lot of organs in it. We're actually going to move to the next slide here. As you can see right here, you have a lot going on in your abdomen. So we try to cut it into sections so that we can reference things a little bit easier and so we know what's in that area a little bit better. So we have two lines that we use going over this guy. You have one that follows your midline right down the middle and goes right through the middle of your belly button. Then you have one that goes across the half, again, right through the belly button. So this is what separates your four quadrants, is what we call it, because it's four areas. So we refer to them, again, on the patient's side. You have your right side and your left side, and you have your upper and lower. So right here would be your right upper quadrant, RUQ. Right here would be your right lower quadrant, RLQ. Over here would be your left lower quadrant, LLQ. And right here would be your left upper quadrant, LUQ. So those are our different quadrants. It's acceptable to write these abbreviations when you're documenting. It's more acceptable to say the actual quadrant if you're speaking to someone. So if I'm talking to you person to person, I say the patient has an injury to the right upper quadrant. That's more acceptable than saying the patient has an injury to their RUQ. It's just a little awkward to say that abbreviation in person. But if I'm documenting, I can say injury is found to the RUQ. And then over here, you just have all the different things that go on each quadrant. Again, this is helpful to divide these quadrants, because if I say the injury is to the right upper quadrant, you now know that the right upper quadrant is a lot of liver. It mostly is liver. It has some of your right kidney in it, a little colon in it, the head of your pancreas is in it, and your gallbladder, which is attached to liver. But it's mostly liver. So if we have an injury to the right upper quadrant, say someone who got stabbed in the right upper quadrant, we're really going to be concerned about the liver, versus if I just said it was in the abdomen, it could be any of these options, and we're probably thinking intestine, because that takes up a lot of your lower quadrants is intestine, whether it be small or large. But if I can specify saying injuries to the right upper quadrant, we now know that we're limited to these organs. So these will all be covered in anatomy and physiology throughout the class, really. So you don't have to learn these in this class per se, this one chapter, but it will be covered throughout class, and by the end of class, you should know where everything is. So right here is a handout went through class, just so we could review all the different terms. So we'll just really quickly go through this. So this guy right here, we have a view, and this is what we're looking at. It's the anterior view. This guy right here, since we're looking at the back, the view is the posterior view. So if anterior goes right there, and posterior goes right here. Okay. Going down the middle, we have our midline, or our median plane right there. Then we have two lines going on either side of the chest. Those are your midclavicular lines. Then we have this plane right here dividing the legs from the rest of the body. That's your transverse plane. So right here is your abdomen. So you have your two cross sections. So you have your right upper quadrant, right lower quadrant, left upper quadrant, and left lower quadrant. So that's this guy right here. Moving on to here, we have some directional terms. So we have the arm. So going towards the torso is proximal. Going away from the torso is distal. Right here, same thing. We're going towards the torso, so that's proximal. Away from the torso is distal. Here, we're looking at the entire body, so going towards the head, we have superior. Going away from the head, we have inferior. Then we have our midline right here. So going towards the midline, that's what these two arrows are doing. Going up here, that's medial. And going away from the midline is these two guys here. That's lateral. So that's this guy right here. Then right here, we have our frontal plane, divides the body into two sides. Right next to it, really it kind of shares the line, but I had to put them separately. This line right here is your mid-axillary line. So that's this body right here. If you notice, I was able to rattle these off very quickly, because these are terms that you have to have down pat. I've been in the field for 10 years. I've used these terms for 10 years, so I know these without having to think twice about it. But this is the level that we want you guys to get at, especially before the end of class. So moving on to some positional terms. Positional terms are important because this is how we can communicate how we transported someone or how I found someone. So knowing the different positions, and then in the class we're going to discuss why we keep people in some of these positions based off their medical complaint, is really key. So supine is the term that we use for someone who's laying flat on their back. You'll see an example of that in the next slide. Prone is someone who's laying flat on their front. You'll see an example of that, I think, in 2 slides. Then your recovery position is someone who's laying on their side. Another word for recovery is lateral, which means side, recumbent. So you can say left lateral recumbent or right lateral recumbent, depending on which side of their body they're laying on, their left or right side. And that's our preferred position for any unconscious patient that you're not suspecting trauma, because being on your side allows for anything that's in the airway to kind of help drain out, so it's not kept in the back of your throat if you're laying on your back. So it helps it drain it out. So here's an example of a supine position, laying flat on your back. And an example of your prone position, laying flat on your face. There is almost no instance in EMS where we want to keep someone in a prone position. So people always go onto their backs, except in very, very, very rare circumstances. And here is your recovery position, or your lateral recumbent position. Some other terms that we use is the Fowler or semi-Fowler position. So right here is an example of the semi-Fowler position. Semi-Fowler position is defined as your legs are flat, so this guy's legs are flat on a bed, and then you are sitting up halfway in the semi-Fowler. So semi-Fowler is really 45 degrees and below is semi-Fowler position. So this guy is right around 45 degrees, so he's semi-Fowler. Then 45 degrees and above to 90 is your Fowler position. So Fowler position is sitting pretty straight up. Semi-Fowler is kind of relaxed. Most of our patients are transported in this position right here because it's pretty comfortable, or at least as comfortable as we can make them on the stretcher. So most of our patients are transported in the semi-Fowler position. So it's an important term to know because that's how we have to describe the majority of our patients being transported to what position they're in. This is just wrapping that up between the difference between Fowler and semi-Fowler. Moving into some chapter review. So remember, medicine has a language of its own. As an EMT, you frequently communicate with medical professionals who speak this language. Also remember that you communicate with your patients who don't, so you have to know when and when not to use your medical terms. Medical terms generally consist of a root with a prefix and or suffix. So as long as you learn your prefixes, suffixes, and roots, you can piece together most terms that you're going to hear. Medical terminology is the language of healthcare. Roots, prefixes, and suffixes can lend clues to the meaning of many terms. And branching off that, if you encounter a situation where you're taking over care from a doctor, let's say you're called to a doctor's office and they're giving you a report on the patient, and they use a term that you don't know, or they talk about disease processes that you don't know, please don't hesitate to ask. It is much better that they break it down into plain language for you than for you to just pretend that you know what they're talking about, and then you end up missing something on your assessment where you treat the patient inappropriately because you don't know what the patient is dealing with. So moving on, understanding anatomy and physiology is kind of like reviewing the owner's manual for the body. Again, we're going to discuss anatomy and physiology in depth in the next chapter. And then anatomical terminology brings precision and accuracy to descriptions, which is huge for us because we have to describe what happens to patients both in documentation and in real time to a doctor. We have to be their eyes and ears, so we need precision and accuracy in our descriptions and a language that everyone in healthcare understands. So throughout your career, always consider, is your use of medical terms accurate and descriptive? And also be sure that you can identify critical organs and structures that reside inside an area where a patient has a complaint or traumatic injury. Again, if someone has a injury to the right upper quadrant, know what's in that right upper quadrant. It's easy to remember because it's mostly liver, but you need to be able to recognize that so that if someone is, say, stabbed there, you know the liver, and we'll talk about this in anatomy and physiology, but the liver houses a lot of blood. Its job is to kind of cleanse the blood, so a lot of blood goes through there, and if that's stabbed, it's going to be a source of some hefty bleeding because of all the blood that circulates throughout there. So knowing that versus if someone's stabbed in their right lower quadrant where it's mostly intestine, we aren't going to see as much bleeding. We're going to see more intestinal issues there. So be sure that you can identify critical organs and where they are. Again, we're going to cover this in depth in anatomy and physiology. All right, so it ends with a quick question. I'm not going to spend too much time on it. But if you want to kind of get a worksheet out and write down where these injuries are and try to make sure that you can identify where they are and make it into anatomical terms that you can present to someone else, that's what this is for. So you respond to a teenage boy who has taken a hard fall from his dirt bike. He has a deep gash on the outside of his left arm, halfway between his shoulder and elbow, and another on the inside of his right arm, just above the wrist. His left leg is bent at a funny angle, about halfway between the hip and the knee. When you cut away the pant's leg, you see a bone sticking out of a wound on the front side. So just think, how would you describe your patient's injuries over the radio to hospital staff? So again, you can rewind and read the question again if you want and think about where they are, kind of point them out on yourself or on a diagram, and then think about how you would describe that to someone in anatomical terms. So that brings us to the end of this chapter. A lot of ground covered. Again, medical terminology is an entire course in college. It can be several different courses. People can spend years learning medical terminology. The point of this class is to give you the basics and the roots to get growing in medical terminology. I'm not here to try to teach you every single word and its meaning, but if I can teach you how to break a lot of words down, it's going to be a great start for your career. So, as always, if you have any questions, if you need the diagrams that were sent to class out again, always feel free to reach out to me.